Welcome to SNF This, the podcast where we pull back the bed sheets on skilled nursing facilities, educating, entertaining, and occasionally risking being reported to HR. Welcome back to this episode of SNF This. Excited to have my good friends back. Last time we got knee deep in urinalysis and treatment and went over a little over time. So wanted to bring these guys back and talk about another topic that's really important in the skilled nursing facility setting. I'll quickly have Aaron and Noah just give the 20-second reminder of who they are and their background, and then we'll get right into it. But Dr. Anderson, good to have you back. Thanks for coming back.
Yeah, thanks for having me back. Wore the same shirt just so that Aaron Anderson. I'm the Chief Medical Officer for Gadzoom Health, which is a medical directorship company that's based out of Utah, and we also service buildings in Nevada and Texas. I have a family medicine background, practiced medicine for a lot of years as an outpatient, and have been doing SNF work for the past 5 years.
Awesome. Yeah. It's always fun to work with you and appreciate your partnership.
Yeah, you too.
You always look good. You're always like set. Just maybe the sports med background. You're in the fitness. You're good. Oh, someday we still need to go golfing though.
We will.
You've promised me multiple times. So.
I'll shoot you a text.
Okay. Yeah. That's what he always says. Okay. And then we got Noah.
I was just going to say the t-shirt is continuity of care, really.
We don't have very much options on our white t-shirts,
but yeah, I'm Noah Dobson, physician assistant and background in family medicine and urgent care, and then just have been with Vital Care from the very beginning. So I'm in the trenches with all these other providers providing care for our dear patients at these skilled nursing facilities.
Awesome. Yeah, and it's so much fun to work with you guys, and appreciate the work you're doing. One of the things we didn't get to last time, and hoping to discuss at length today, and I think we're going to try to keep it just to that, is electrolytes. So we get a lab in the facility, and when I was more of a rounding provider, I always ran into this where I'd get a lab result and I'm following up from another provider, and there's not great documentation of why we got the lab in the first place. So then what do I do about some of these lab results, and particular electrolytes? So we have pretty consistently hyperkalemia or hyponatremia, or in terms of the lab interpretation, when should we be worried? What's kind of your approach to approaching electrolytes, and some of the specific things with potassium or sodium or calcium or magnesium, in terms of replacement for that? What's a little bit of your approach towards that, Dr. Anderson?
I think the first thing that I think about when I hear that, the first question that I used to get about that was somebody would come back with a hyponatremia, for example, and their question would be, what should I give them? And I don't think that's the right approach in this kind of a situation, because our questions should never be, how do I treat this? Because basically we're asking, how do I treat this symptom? So I think the first thing we have to ask is, what's causing that symptom? So what's the reason that they have the lab that they have? And that's easier said than done. Obviously, there's a lot that goes into that, but that's not it. We definitely have to get away from treatment first, and it's diagnosis first, and then we can treat it. The reason behind that is that these labs are in the context of a very specific patient. So anemia is a really helpful example, because hemoglobin and hematocrit are very dependent on volume. Yeah. Right. So if you have a patient who is euvolemic, meaning they don't have too much or too little fluid, that patient's going to have their red blood cell count means something, as opposed to a patient that is hypervolemic. It's going to make their hemoglobin and hematocrit look small. And whereas if they're dehydrated, it's going to make it look too high. Right. Because it's in the context of that patient. So when you're looking at a patient who has a low hemoglobin, you might say, well, do we need to transfuse that patient? And again, that's thinking treatment first, as opposed to what's the cause of their anemia? Is it a volume status issue? Do they have iron deficiency anemia? Do they have anemia of chronic disease? Are they bleeding? And if so, where are they bleeding from?
Right.
Or is it blood loss? And that's going to really affect and drive how we look at treatment in those situations. And it's really no different with electrolyte abnormalities. If they're hyponatremic, it can be related to volume status. Again, it can be related to kidney issues, which is the primary excreter of most of the electrolytes that we have. And so we're looking at those lab abnormalities in the context of what's causing that abnormality. And so I think if we do that first, then we can get on to how we treat it. But that's really the first question that we've got to ask. And then the second thing I would say to that is that it also depends in the context of that particular lab, like what their trend is. Looking at a lab in isolation, it's rarely that helpful. Because if you have somebody who has a little bit of hyponatremia, but they're chronically hyponatremic, that's very different than somebody who lives in a normal state of
right.
sodium balance and now is hyponatremic,
right.
Even if it's just mild. And so we have to look at those things in the context of both the patient and their trends to kind of figure out what we're going to do about the lab.
No, I think that's a really good feedback, because I do get into that trap sometimes, and the podcast is like this ultimate confessional here, but I get in this like trap of like, while they're talking, trying to think about what the treatment would be out of the context of like maybe really what's going on. And we actually had a conversation before this about it was triggered by something. So something happened, or the patient is feeling some way, or they're on some sort of medication that this lab was drawn in the first place. And so now we're then faced with now what do we do with this lab? Are we worried about this patient? And common, I'll get a call where like they're hyperkalemic. And like I talk to the patient, they generally they're in normal range. Normally they're not on like spironolactone or a diuretic that would like skew this in any way. My first thought is like going towards like, oh, man, is this sample drawn right? Was there some sort of error? Which maybe is not the best approach, but it's one of the considerations that I think we have to make, especially when we're like talking about electrolytes, is like, how is this obtained and in what setting? And are they euvolemic, or are they hypo or hyper? And so in the setting of that, like sometimes electrolytes can scare people given in one snapshot. And I liked your perspective that electrolytes in labs are really only beneficial in like a trending, especially with electrolytes, I think. But so I think electrolytes for us tend to be like a red flag. Like I'll get calls from providers who are like, oh man, their potassium's 7. And I'm like, ooh, that's pretty good. Like, how are they? Well, they're fine. Like, any chest pain, any cardiac, anything? And they're like, no. And I'm, well, then maybe we need to do a little bit more digging, like in the context of, rather than looking for the treatment, like we're looking for the diagnoses, like what's the problem that's going on. So I like that perspective.
Yeah. And I think as a provider that is taking some of these acute calls too, we get these one labs and we want to see the trends. And there's not always access to the trends on our end. And so is it okay, and is a trend good enough if patient is stable, asymptomatic, that we redraw in 24, 48 hours? Like, does that give us enough information?
Definitely, because it all comes back to, is the patient stable?
Right.
Do they have any chest pain? Are they normal from a mental status standpoint? Because if they are, then you can feel a lot more comfortable taking your time and figuring out, again, do we need to redraw the lab, which is something that's commonly overlooked. Yeah. Or can we just manage the patient in-house since they have an abnormal lab? And I think those do depend on, again, the context of the patient. So for some of those things, if they do have like cardiac abnormalities, you're going to have a lower threshold to send that patient maybe to the hospital to be evaluated than a relatively healthy patient who maybe has a fracture or something. They're just managing that. So I think there are certain cutoffs that are kind of hard, right? Like if we have a sodium of like under 125, 120, 125, That's severe. And it's probably not something that's worth waiting, because in the SNF setting, we don't do hypertonic saline drips. That's just not something that we do. And we're happy to send the patient to the hospital for that, to get corrected. And the reason behind that is that it's just, you can't correct too fast, and you can correct too slow as well. So there's kind of an optimal range where you want to hit that 10 to 12 milliequivalent per day kind of target,
right?
So that you don't end up with like the demyelination syndromes and some of those cerebral edema kind of issues that you get with correcting too fast.
We do have providers who work in critical care settings that are taking these calls as well, or on the side are rounding in a SNF, or that want to be aggressive about this treatment. And sometimes I get questions about, should I start them on a drip, like electrolyte replacement? And I'm like, time out, guys. Like, remember the setting that we're in. Generally, replacing electrolytes would require some sort of monitoring, like telemetry, some sort of cardiac monitoring. We're in a more acute setting. And so if we're in a setting where like we feel like we're going to need to replace those electrolytes quicker or more acutely, I agree with you. I think those are where hands are tied a little bit, but the best place for them to be to replace that would be in the hospital. As much as we are worried about sending these patients out to the hospital because of all the ramifications for it, electrolytes can be that. But I think important to talk about how to interpret those like electrolytes. So and I'm always trying to figure out, like, with a patient that's like hyperkalemic, like, is there anything that you give? Like, there's Localma, there's some other things that are out there that like theoretically lower the potassium safely from an oral PO perspective. Do you use that type of medication or routes, like with hyperkalemia or any other electrolytes in the facility?
For sure, like calcium, insulin can be given to lower potassium. So there's quite a few different things that you can use. And I think those are great strategies, especially when the patient is asymptomatic or minimally symptomatic. You can safely use those medications in the facility.
One of the like acute treatment things that I like to use in a SNF setting for potassium that is maybe high, and we verified that is high, like you said, is insulin.
Yeah.
Sometimes the nurses get really nervous about that, but we can watch their blood glucose. We can check it pretty regularly. You give them a good dose of like a couple of units of insulin, it pulls the potassium into the cell. You have this natural reduction in potassium. So I think there is some acute things that we can do, but I think a lot of it comes back to are they symptomatic, like chest pain, like where have they been? Why did we draw the lab?
Right. And I think your point about we're really trying to reduce readmissions to the hospital. The reason behind that is transfers of care are going to cause a lot of errors, medication errors, and there's going to be a lot of morbidity related to those transfers. But the transfer rate should never be zero. There should be, there are perfectly appropriate reasons to send patients to the hospital, and a severe electrolyte abnormality with a symptomatic patient is absolutely one of them. So feeling comfortable sending those patients to the hospital, I think you should feel good about that. That's great. Send that patient out to the right level of care so that we can correct those things is perfectly appropriate. But yeah, to your point about hyperkalemia and there's a bunch of different treatments that you can use. And so again, safely using some of those in an asymptomatic patient, it all depends. Again, you can't just look at a number. You can't say, oh, patient 6, send them. It's got to be more like, okay, the patient's 6, but doing great, insulin, calcium, IV calcium, those kinds of things can totally be used, and you can feel comfortable with that. Reminding them also that we need to do frequent monitoring, and that's not the end of the treatment. We should be redrawing labs and monitoring them much closer.
When I think the point is not treating the number. I remember, it just reminded me, it was a couple of years ago, but I got a call about a potassium, like it was 12, and I'm like, not possible.
No.
Like, they're like, it says it's 12, and I'm like, not possible. they're not alive, right? And my point in that is, like, I think we also need to make sure that we're looking at the patient. Going back to our training, we can't just take a number and treat a number. We need to be assessing the patient. We need to be talking to them. And we can't always, as a provider, just take the information from the nurse. As helpful as they are, just like providers, there's good providers and providers who need improvement. They're same on the nursing side. Like there's great nurses who maybe need a little bit more hand-holding and education. But we can't just take their like what they're saying or like a specific number in treatment. I think that's part of that decision process, but it's not the whole process. And so examining the patient and talking to them is an important part of that too.
And I think one of the other like scenarios I've run into, especially with like hyperkalemia, is the nurse calls, I suggest maybe a redraw, and then I usually want to get like an EKG to see if there is any peak T waves changes that I would be concerned about. The dilemma I run into is the turnaround time with the EKG. Do you have like a general rule of thumb of when you need that EKG done and read?
I don't know that there is a rule for that. I think a little of that goes back to the patient as a whole. Mm-hmm. Are they at high risk for that kind of thing? Is this a really steep increase in their potassium? Or has this been a gradual thing? Or do they have any symptoms at all? I think those are kind of what would, because I don't think you can just say it's got to be within 12 hours because it's going to be pretty different for every patient. I do find that to be a common issue. I think where I've run into this the most is with patients who have like a suspected MI, and the question is, should I get enzymes, get an EKG and enzymes? And my answer to that is, if you really think they're having an MI, send them to the hospital. Right? Get those enzymes. If you really think that's necessary, don't get them as an outpatient lab. Yeah. You got to send them. So I think in this kind of situation, if you really feel like, man, I got to get this EKG, this patient's not doing well, they should just go to the hospital and get it. And if they're asymptomatic and it's a slow increase and it's maybe 6.1, it's in that range where it's not severely elevated, you could probably get away with getting an EKG and waiting for the morning when you can actually look at it.
That's awesome. Thanks, Dr. Anderson.
Yeah.
Thank you, Noah. Yeah. Electrolytes, kind of like we talked last episode, around like treating UTIs and UAs, it's important to like involve the whole process and the patient being really important to that. Are they symptomatic or are they not? And are they stable? Or are they not? I always feel like, man, if the patient's stable, I have a little bit of time to figure this out. If they're acutely ill and rapidly declining, they should be going to the hospital anyways, especially in this sort of skilled nursing facility setting. And so there is some things that we can do as long as they're asymptomatic and they're stable. And I really liked one big takeaway for me today is just talking about, we're not looking for treatment right away. We're looking for the disease, the diagnosis. We're treating the patient, not the number. And it's good to have that reminder often. So thank you so much for that. My favorite part of the episode. You guys hate this.
It's my favorite part now too.
Oh yeah,
it's my favorite part.
I've been nice to you guys, and I won't tell you if I'm nice today, but we'll just pass these out. Here you go. We did talk about UAs, UTIs last time.
It's a little foamy.
Some protein.
Mine kind of looks a little dirty.
Some little protein. If that was a UA, we'd be in big trouble.
Oh man, I know what that is.
Okay.
I hope it's not gross. I got a little on my mouth.
Don't lick that. Just
So that one smells like apple cinnamon oatmeal.
Oh, I could see that. I could see that.
Yeah, like a cinnamon protein calorie drink is kind of what it.
Yeah, this is a protein shake. I think the label is like vanilla bean.
Vanilla bean.
Oh, it's
cinnamon?
Cinnamon apple? You don't get that?
Maybe it's a little nutmeg.
I get the. I wanted to gag. I don't know. I get the cinnamon out of that, but that's like a vanilla bean protein shake. You're welcome to drink it now.
No.
And that smells like an energy drink. I was going to say taste, but I didn't taste it.
What's your take on this, Noah?
Some sort of carbonated beverage, maybe grapefruit.
Yeah, it's just a sparkling water. So like strawberry something, like an Izzy or something, but it's good. You guys are welcome to take these as a your
gift?
going away gift
Thanks,
for being on the podcast. But grateful for both of you again. Always great to be with you. I always take away a lot and learn a lot. So thanks again for being here. We'll be excited to reconnect sometime in the future. We'll have both of you on. But thanks for listening in on this episode of SNF This, and we'll catch you next time. Before we conclude, huge thanks to our sponsor, VitalCare Connect. Whether you're burning the midnight oil or just trying to survive another 2 a.m. call, VitalCare Connect provides on-call medical director support whenever you need it, nights, weekends, and holidays. With coverage nationwide, they're leading the way in post-acute care, elevating quality, expanding access, and supporting well-being for all. Learn more at vitalcare.org. Thank you for joining us for this episode of SNF This. Share this show with your favorite CNA or anyone who's survived an all-staff meeting fueled by cold coffee. Until next time, I'm Chance. In skilled nursing, if you sniff something, say something.